Thanks for joining us today. Happy NP Week. I'm Erica Bloom, and I'm the Product Marketing Manager at Springer Publishing. Today, we're presenting Gynecology Tips and Tricks, treating Bartholin's Gland Abscess with confidence, with Aimee, Holland, Professor and the Associate Dean for Graduate Clinical Education at the University of Alabama at Birmingham School of Nursing, and Kelley Borella, Assistant Professor and the Director for the Nurse Practitioner Pathway at the University of Alabama at Birmingham. Before we get started, I just want to mention that this webinar will be recorded. If you miss any portion of the presentation, you can find the video on Springer Publishing's website 5 to 7 days post-event. And if you have any questions, please type them in the Q&A box on your Zoom control panel. And without further ado, I'll hand it over to you guys.
Thank you, Erica. Welcome, everyone. My name is Aimee Holland, and I am presenting today with co-author of Chapter 52, An Advanced Health Assessment of Women. Yay! Kelley Borella, my co-host today. And we also have another author, Helen Carcio of Chapter 52. So we want to give Dr. Carcio props. Today we're talking about Chapter 52, but we can't talk about this book without giving props to Dr. Mimi Secor, who is co-editor of the book with me. And Mimi is kicking cancer in the butt as we speak. If you're not following Mimi's amazing journey on Facebook, please join her page and check in on her and send her some love. And Mimi is here with us in spirit today. She talked to her this morning. She is fighting hard and recovering from GYN cancer of the tube, which she found and advocated for herself with her nurse practitioner to identify what was causing her symptoms. So we send Mimi a big hug and thank her for all that she is doing for women's health, and it has done. So without further ado, let's get started. So gynecology tips and tricks, treating Bartholin's gland abscess with confidence. So today what we are going to do is discuss when to perform incision and drainage. So we are discussing when to perform an incision and drainage of a Bartholin's gland abscess. We'll talk about the evidence-based rationale for ordering the procedure, and then identify the correct steps for safely and accurately performing the procedure, followed by a demonstration. We'll watch a video. We'll talk about pharmacology and other treatment methods, and then we'll wrap it up. So, Dr. Borella, tell us about the incision and drainage of a Bartholin gland abscess with word catheter placement.
Okay, so the reason that we do this procedure is really just for relief of symptoms. So most of the time your patient is going to present with pain, just very uncomfortable, and truly once you do this procedure, she is going to thank you for it because it is really uncomfortable for them. So the reason that we do this is for the relief of those symptoms. I'm sorry, I'm having to look away from the camera so I can see my screen that I'm showing to you because it's not showing up for me. So I'm going to kind of talk through a little bit of a step-by-step procedure. And then I think the easiest thing to do would be to show you the video just so that you can see how it's done, because I think being able to visualize it is going to help you a lot. So the very first thing that you're going to do, like with any procedure, is have the patient sign a consent. You're going to have the patient in lithotomy position. So they're in your office, in the GYN office, up in the stirrups. And you're going to clean that area of the Bartholin's abscess really well. You can either use betadine. If the patient is allergic, you can use something like chlorhexidine, whatever your clinic protocols call for. Next, you want to inject the area that you're going to be INDing with 1% lidocaine. And you want to make sure that you're going to make a wheel around the area that you're going to inject. And this may include, and is going to include, part of that abscess. So one tip that I will tell you that will come in handy is you want to wear either goggles or you need a mask that has a face covering for you, because I've had that happen to me so many times. They're under so much pressure that anything that you do will cause them to go ahead and begin to drain. Once you do that, you're going to use an 11 or 15 blade scalpel to make a jabbing stab. So this is not, you're not trying to excise anything and you're not trying to take anything away. You're basically just poking a hole in it. So you're going to make a jabbing stab. And then before you have a chance to, or before the abscess has a chance to close down on itself, that's when you're going to put in the word catheter. So unlike all of the other abscesses that you may have IND'd in the past, where you have drained the abscess and then cleaned it thoroughly before even packing it, you're not going to do that with this particular abscess. And the reason for that is because we want to get this word catheter into that gland. And if you drain all of the purulent discharge that's in there out, you won't be able to actually place the catheter into that area. It will have collapsed down on itself. So you want to make your jabbing stab and then have your word catheter ready to go ahead and insert. You want to fill the bulb up with 2 to 3 centimeters of water. These word catheters are very much like a Foley catheter. They work in the same way. So you fill the bulb up the same way, and we'll show you in just a little bit with the video how you can check to make sure that the bulb is working and that this is going to be something that's going to work for the patient. Also, you do want to make sure too that you're going to keep the word catheter on the syringe, on the needle, and that will be in the video as well, because you're going to use that needle to help guide that catheter into place. You'll remove the needle from the catheter once you fill up the bulb, and then you're going to tuck the distal end of the catheter into the vagina. And then you want the patient to follow up in about two weeks. You're hoping that the catheter is going to stay in place. A lot of times they don't stay in place. We were just talking about a study that was done in 2015 where they looked at 26 patients who had word catheter placement, and 11 of those patients came back after 4 weeks with having this catheter still in place, which is pretty amazing to me, because a lot of times with our patients, they just don't. It's in, they're going to go to the bathroom. It's just in a bad place. They're sitting on it. It can get caught on clothes. So you want it to stay in as long as it can. Ideally, it would stay in for 4 weeks, but you do want them to come back after about 2 weeks so that you can take a look at the area and check to see how it is healing. Before I show the video, Dr. Holland, did you have anything that you might want to add?
Yeah, so this continues to be the gold standard for treatment of Bartholin gland abscess. And in every study I've ever looked at, there was some, I don't like to say guarantee, because with research, there is no guarantee. It's just, but with every literature that all the literature that I've looked at, they're showed or they're demonstrated that there was some relief of the symptoms and then treatment healing as a result of utilizing the word catheter. So it continues to be the gold treatment for this abscess.
So I'll go ahead. I'm going to stop sharing my screen so that I can share with you the video. Having to go a little bit back and forth, so you all tell me if you can see this video.
Yes, we can.
Okay.
This is a simulation of an incision and drainage of the Bartholin gland abscess with a word catheter placement. I'd like to show you how I created this simulation. Taking the end of a glove, a clean glove, oatmeal and water were mixed and placed, and the area was secured off and then cut. That was then placed under the first layer of a chicken thigh. Any chicken wing, chicken breast, chicken leg, anything could be used. In addition to calf liver can be used also. All right, when performing this procedure, you should first review with the patient any risk and benefits associated with this procedure and obtain a signed informed consent. That should be placed on the chart. Then confirm any allergies that the patient has. Then place the patient in the lithotomy position. The practitioner should wash their hands and apply gloves. Good lighting is important to be able to visualize the area of the Bartholin's gland abscess. Inside of the labia minora, that is where the incision should be made. So that is where the area should first be cleaned. All right, clean the area. Then I'm going to take lidocaine. This is just simulated water. Simulate lidocaine, 2 to 3 cc's. And I will inject the area around in the subacute area to numb the area before the procedure is performed. I'll pull the skin taut and then form a small wheal. Okay. As that is numbing the patient's vulva, I will make sure that the word catheter will inflate appropriately. This is done with normal saline or with tap water. It doesn't matter. The word catheter, I have a needle placed right into the underside. You can see where you place the needle. Gently push it inside of the area. And then insert the water to make sure that the valve inflates appropriately and does not leak. Then I'll remove it, much like a Foley catheter. And actually, a Foley catheter can be used to perform this if you don't have a word catheter. But a word catheter is what's recommended. All right, so I made sure that worked. So I replace the needle inside. Now I'll ask the patient if they feel me touching. And if they don't, then I know I'm ready to perform the procedure. A 9 or 11 size blade should be obtained. Like I said, inside of the hymenal ring of the labia majora, a jabbing stab should be made. And as you can see, the contents are being dissolved. So you quickly, before the abscess runs out, you want to insert the word catheter inside, or you won't be able to. Then I'll gently remove the needle. Make sure that it won't come out. And then I tuck the underside, I tuck the other side of the word catheter inside of the vagina. This keeps it from being pulled or snagged otherwise. And this concludes the incision and drainage and insertion of a word catheter into a Bartholin's gland cyst or abscess.
Okay. Give me just 1 second and I will share my other screen again. So helpful hints. You might want to consider using a hemostat to break up any loculations that have formed within the abscess to make it a little bit more easy to insert that the catheter. But again, remember that you're not going to have a whole lot of time to do that because these are may not be as forgiving as the oatmeal was. They sort of drain down pretty quickly sometimes, and depending on what size of the incision that you're making. Again, you don't want to make an incision that's too big because the catheter won't be able to stay in place. We talked about tucking it in, we talked about inserting it quickly. You are going to tuck the word catheter into the vagina after the procedure. I always have participants ask why in the world you would do that, because it would seem as if that means that the Bartholin's abscess is going to drain into the vagina, but it does not. That word catheter, the little hole at the bottom of that word catheter that she showed you, it's a closed system. That's just for you to be able to fill up that bulb that's inside. So what's actually happening is that the abscess is draining around that word catheter. And so it's helping to allow that abscess to heal by secondary intention. So again, you want to leave the catheter in place for 4 to 6 weeks if they can. You're hoping that they can. If it falls out at all, you're probably not, you won't be able to get the catheter back in. Oftentimes, even if it falls out while they're still in the office, it will be too late and you can't get the catheter back in. So you want to make sure that you're giving them really good discharge instructions, including, nothing in the vagina for 4 to 6 weeks, as long as they have the catheter in place. And again, they can take, warm sitz baths, that kind of thing, but they just do need to be really careful. They can use ibuprofen if they need it for pain control, and they very well may need pain control. And then antibiotics are really rarely necessary for the procedure. You're not really going to do an excisional biopsy. You don't really need to do that unless there's a presence of something that is irregular, nodular, something different than what your typical Bartholin's gland abscess is going to appear like. And, if this is something that's new to you when you're doing it, I would, definitely get someone to come in and take a look and just get a second opinion on what it is before you put the word catheter or try to drain the abscess itself. The other thing I was going to tell you, and I'm going to see, can you all see this word catheter that I have in this needle?
Yes.
The catheter is really, really flimsy and easy for this needle to just break through. So I have found that if I just take the catheter and just place it, just lay it gently on top of the needle and then just pull straight down, I have been successful in not puncturing the catheter so that you're not able to use it. And then once you have it on there, you can fill it up to make sure that the bulb is inflating. And then what I do is I usually just allow that saline to go back into the syringe, and I just leave it alone once I have it on there, just because they are so easy to puncture. Dr. Holland, do you have any more helpful hints that I have forgotten or that you may want to include?
I think that's a great helpful hint, because the last thing you want to happen, Dr. Borella, is to do everything, have it ready to go, and try to inflate it, and the bulb won't inflate. And that has happened to me before when I've tried to inflate before the procedure and it didn't inflate. They get old, they get crusty, and they don't work sometimes. So always, always, always check it first and make sure that the bulb will inflate before you do the incision and drainage. The other thing I noticed, I was looking over the literature recently, and I noticed that needle aspiration is being done. There's been one study I saw recently in 2022 where the use of needle aspiration was used to relieve the symptoms. You and I had discussed that, and we said we need a research to show long term how good of a treatment, because you and I both said, yeah, but it's going to fill back up. But I guess if patient satisfaction of the relief is the goal, then definitely anybody could do needle aspiration to give them some relief. But this is still considered gold standard treatment and makes sense. What else did we talk about when we were talking about that study, Kelley?
So we actually were just talking about the fact that in that study, they did, patients, 51% of the patients who had the simple needle aspiration did have some relief, or did comment that they had relief of their symptoms, and they will, because again, what's causing that pain, it's an abscess. So as soon as you can get rid of, or, start to drain the stuff that's causing the abscess, they're immediately going to feel relief from that. The biggest issue, like Dr. Holland was saying, is whether or not this will work long term. So again, kind of like what we were talking about with the word catheter, the reason that we want something there is to allow this gland to heal by secondary intention. If you drain that abscess, there is a possibility that you still have some of the bacteria that was there before causing the abscess that just kind of gets closed up again, and then you have another abscess that forms. And I think in my practice, and I think probably Dr. Holland would agree, patients that have these, you often see recurrences. It's often the same patients come back to have another they have another Bartholin's abscess and you're doing another procedure on them, until finally we end up doing the marsupialization, which is just removal of that gland. So it'll be interesting to see what the research shows as far as long-term relief, and without having a secondary abscess come up from that simple needle aspiration. Also, we talked about a study that was done in 2023, or an article that was written in 2023, that indicated that the majority of Bartholin's abscesses occur after the onset of puberty and really decrease after menopause, which would indicate that this is more related to hormones versus maybe how we used to think in the past, that this was more related to infections like gonorrhea and chlamydia. And I remember when I first started practicing, we used to actually test for those things related to the Bartholin's abscess, which we don't recommend anymore unless they have symptoms that are related to gonorrhea or chlamydia, that being totally separate. So,
and ironically, E. coli continues to be the primary culprit here. That's what we are seeing over and over in the literature. It's E. coli is the culprit. So, and it makes sense if you think about it, because the Bartholin's gland is the primary gland that helps with secretions, specifically during sex. And we know that abrasions can cause the ability for bacteria to get in and cause an abscess. So it makes sense. But yeah, it's interesting. So following that literature and evidence-based practice is so important to our practice.
I think one of the most interesting cases that we have talked about would be one that was done in 2015, looking at the number of catheter losses before 4 weeks. Because again, like I said, patients, they need to understand how to take care of these catheters, because it's real easy for these to be pulled out. You can imagine just with the location and where it is. But in this one particular study, in 87% of the cases, where they had 26% participants, only 11 of those 26 were able to, keep the catheter for the entire 4 weeks, which is actually a lot higher than what I was thinking, because I don't know that I've ever really had a patient come back after 4 weeks. So this is great that, and it all boils down to, patient compliance and taking care of it. But they are very, very easy to fall out on their own. And then once they do, just about 9 times out of 10, you have a patient call you to ask if you can put that catheter back in. And unfortunately, you can't.
No, you can't. Because when it's deflated, you can't get anything in. But I think that study and all the other studies I've ever looked at do demonstrate or show or suggest that the word catheter helps. It helps with treatment. It helps with preventing the abscess to fill up again. So this is the gold standard for treatment.
Exactly.
But I really like the idea of needle aspiration. I have a lot of colleagues in the ER that'll say, we don't have our catheters in the ER. What can we do to help when they come? Well, based on that study, and it looks like there's potentially more on the horizon, needle aspiration will at least give them some relief. And then they can get in to see OBGYN or family medicine or whoever they see for their primary care to help, or their women's health as well.
Exactly. And that brings up another great point. We also, in the video that I was showing, at the end of the video, Dr. Holland shows how you can actually use iodoform packing to pack one of these abscesses if you don't have access to either a word catheter or a Foley catheter. There are several videos actually on our website here at the School of Nursing that included this one, the Bartholin Gland Abscess, that you will have access to. There is actually a link at the end, which I will show you now, that you will get access to where you can go and watch that. But also, I would encourage you to watch the packing with the iodoform too, just in case you don't have access to these catheters. These catheters are still pretty expensive. So depending on where you are, where you're practicing, your practice may not have access to the word catheters. And with that, I think, unless Dr. Holland, if you don't have anything else, we may be ready for questions.
I do not. I just want a correction to the video. I say you can use a Foley catheter, and you can, but it's a pediatric Foley catheter. So I just want to clarify that for you.
Thank you.
Great. Thank you so much. Thank you, Aimee and Kelley, for an excellent and informative presentation. We're going to open it up to questions, but we have one right now. What is the most common cause of this abscess?
Based on the literature, E. coli.
Great.
What else would you add, Kelley?
That was what I was just gonna say that it's E. coli.
Great. And I just want to remind everyone that this presentation will be available 5 to 7 days on springerpub.com and also on the presenter's product page, which is for Advanced Health Assessment of Women, 5th edition. Also, by attending this, you get a coupon code, webinar 23 for 25% off the textbook. And if you guys have any ending remarks?
I would say definitely, if you don't have the book, it's a great reference for clinic. Mimi and I set up this last edition, the 5th edition, to where you can use it in clinic. We added management. So all of the evidence-based management practices are in each of the chapters. We want to give a big shout out to each and every author who has made this book such a wonderful resource for clinical practice. Thanks for Springer Publishing. You all have been amazing to work with. We continue to enjoy working with you, and thanks for all you all do to take care of our patients. I mean, happy Nurse Practitioner Week.
Yes, happy Nurse Practitioners Week.
Thank you so much for joining us today. We really appreciate you guys. Great presentation.
Thank you.
Thank you.